Hello, everyone. Thank you for taking the time to join us this evening for the event Techniques, Tools, and Electrosurgery Settings for Advanced Colonic Polypectomy. My name is Alexandria Alganyan, Associate Product Manager at Snare Endoscopy, and I'll be your host for tonight's session. For your awareness, this presentation is being recorded. During the event, if you have any questions or comments, please submit them at the bottom of the screen using either your chat function or the Q&A drop down at the bottom of the screen. We will address all questions at the end of the presentation. With that, I'm very excited and honored to welcome you to today's virtual event, Techniques, Tools, and Electrosurgery Settings for Advanced Colonic Polypectomy, presented by Dr. Diehl. Dr. Diehl is a highly skilled therapeutic physician and director of interventional endoscopy at Geisinger Medical Center, based in Dansville, PA. With extensive advanced endoscopy experience, he is proficient in advanced cases, including, but not limited to ESD and EMR. Dr. Diehl obtained his medical degree from the University of California, Los Angeles, and then completed his fellowships in gastroenterology at UC San Francisco and UCLA. He then served as faculty at NYU Medical Center. Dr. Diehl, we are eager to hear more about your experiences and recommendations on advanced colonic polypectomy. And with that, I pass the virtual stage to you.
Great, thanks, Alexandria. And thanks to everyone for attending this presentation. Oops. I'd like to thank Steris also for the invitation to do this talk. So I'm going to be talking about how to manage polyps that are out of the ordinary, slightly larger, and there are several important considerations. First is time. So for larger polyps, these can be longer, it could be 30-minute cases or even longer in some cases. There's slightly higher risk to these, but it's important to note that the risk is more delayed bleeding than perforation. And with proper technique, perforation remains a very uncommon complication. The other important consideration is, will you be able to do enough to maintain your skill at doing these? So here's a polyp, and things that are this ugly looking, this is invasive cancer, and just based on the pit pattern. And if you look at the edge, there's this sort of like a white, these little white specks. Those are dilated lymphatics, and that's a sign of malignancy. So if you see something like this, it's malignant. Take your biopsies to make the diagnosis, but you don't have to do a prolonged resection on something like this. Identifying some polyps, sometimes they're very subtle. This is a nice example of a granular polyp. You can basically make it out, and with NBI, it does stand out more. But if you spray some methylene blue, dilute methylene blue over the surface, it really makes it pop, and then you can identify it, even mark the edge and resect this. So keep in mind methylene blue chromoendoscopy, it's sometimes very helpful. We are seeing more flat polyps, particularly in the proximal colon, and this type of polyp called a sessile serrated polyp. These SSPs, they account for about 20% of colorectal cancer. They're a precursor to sporadic colorectal cancer with MSI, microsatellite instability. They can be very subtle, flat, indistinct margins, and clearly there's a higher miss rate on these. And as a result of the edges being indistinct, there's more of an incomplete resection rate. Histologically, you can see it has a sort of a serrated appearance, and that's why they're called serrated polyps. They're typically in the right colon. They can be very hard to detect. Sometimes we see something called a mucus cap, and if you look at that picture, it does look like just maybe some stool covering the mucosa, but that's actually a discolored mucus over one of these SSPs. So you really need a good prep to identify these. Pathology may be similar to a hyperplastic polyp, and sometimes if you see, you know, a good sized polyp, 10 or more millimeters, and you're certain it's a polyp and it comes back as hyperplastic, it may be that this is actually an SSP. And the genetics are different than regular adenomas. Here's an example of a sessile serrated polyp. Might be easy to miss. This is on a fold, and with the methylene blue, it highlights where this polyp is. And there was a mucus cap on this one. after lifting, often it really defines better the edges, as it does in this case. These are very easy to overlook, particularly if the prep is not pristine. There's an important consideration. There's this thing called interval colon cancers, and these are cancers that are diagnosed before the next recommended screening or surveillance colonoscopy. It is the greatest fear of anyone doing colonoscopy, I would say. 2/3 of interval cancers are SSP related, and majority are in the proximal colon. It probably has to do with the growth pattern of these polyps are different. They probably grow faster, and they may not go through the sequence, the adenoma cancer sequence that we see for regular adenomas. Now, this is the tips and tricks part of the presentation. I'm proud to say that I was taking flying lessons. This is a few years ago, and this was after my first solo flight with my great instructor, Diehl. And I learned a lot from the exercise of flying. And I realized that a lot of this applies to endoscopy. So if we fly, we do something called a pre-flight. We check everything. We don't want to get surprised when we're up in the air. So we check all the controls, the gas, the oil, everything. So I realized there's a pre-flight checklist for colonoscopy as well. And it boils down to 7 things. First thing is selecting endoscope. Second, make sure the air is off and you're using CO2 insufflation. Third, the irrigation pump should be connected. 4, a clear cap for the scope is very often helpful. 5, select the devices that you think that you will use. 6, decide on a lifting solution. And last, prepare your cautery device. That is the pre-flight checklist for prior to polypectomy. As far as endoscope selection, I used to use pediatric or slim colonoscopes a lot, but I've since switched mainly to the adult colonoscope, mainly because I really like that large channel. It makes it easier to clean things up and to suction pieces of polyp out. If it's a distal lesion like rectosigmoid, I choose a gastroscope. It's easier to retroflex, easier to manage that scope. All the scopes you use must have an auxiliary water port, and all the colonoscopes do, not all the gastroscopes do. The other thing to check is make sure the knobs should fully deflect the scope tip. Sometimes you get a scope which the cables are stretched out and it's not turning very well, and I will reject that scope and get another one. Regarding CO2, it's very important to use carbon dioxide for insufflation and not air. So make sure that the air is on standby. And I forgot to switch the slide. At US Endoscopy now, Steris has CO2 devices for CO2 insufflation. And I would hope that CO2 insufflation should be universal for all colonoscopy. Connect the pump to the auxiliary water. Here I'm getting a clear cap, and Steris makes a whole selection of clear caps depending on the scope size. And these project a few millimeters out from the tip of the scope, but they very much help looking behind folds. You select the devices that you're going to use. As far as snares, Steris has a very nice selection of snares. The Exacto, of course, everyone's familiar with. Really the first cold snare on the market, and still an excellent device, very sharp, good for cold snaring. I really like the Histolock snare, which is a very predictable performance, and I use that a lot for piecemeal polypectomy. And the newest offering is this coin tip snare, which is nice. It has 3 sizes, so you can use it for larger areas, and you can also use the small size. This is in one snare for example, cold snaring. And it's called coin tip because of the tip of the snare. It's been hammered flat, which is a process called coining, so they call it the coin tip snare, and that maintains the snare shape. So here's an example of cold snaring with in this case, an Exacto. And I've really grown to like cold snaring a lot. Very efficient, very quick, very safe, and it does seem that bleeding is much less after, potential for bleeding is less after cold snaring. A couple of words about the Hislock snare, which I like so much. It's a precision snare. I think it's 14 millimeters across, but it maintains the shape, and you have a very high degree of control with a very predictable performance. It's a stiff snare, so it's very good for grabbing tissue. Obviously, you need an injection needle, a retrieval net. Polyp trap is very useful. Other devices to have on hand: a hot biopsy forceps, and that's for hot avulsion, which I'll be talking about, clips, and some sort of a tattoo. As far as the lifting solution goes, there's the decision points are these: with or without blue dye, with or without epinephrine, and with or without a viscosity agent. I have to say, for most of my cases, I'd certainly use a blue dye, either methylene blue or indigo carmine. It's dilute. You don't want it too blue. The color of Windex, I would say, is what people say is a good color. So lightly blue. I don't use epinephrine generally. Maybe if I'm doing a ESD, I might, but for regular piecemeal polypectomy, I don't use epinephrine. It's similar with a viscosity agent. I use that for ESD. For regular polypectomy, the cases are not as long, and so I haven't found that a viscosity agent is strictly necessary. And then finally, you'll prepare your electrosurgical unit. Make sure the grounding pad is plugged in, and you'd be surprised, I'm sure you've seen this too, how often you're ready to cut, and you're standing there and, oops, forgot to plug in the grounding pad. Now there's 4 settings on the electrosurgical unit that I would like to touch on. And things sort of boil down to these 4. The first one is standard coagulation. And on the GI 4000, you can see it's blue. It's on the screen. On the Irby unit, there's a blue pedal and a yellow pedal. They call it forced coag. The second one is a pulsed type of polypectomy setting, and I use this a lot for flat. This is my preferred for flat polyps. So on the 4000, it's a pulse blend cut or endo cut Q. Soft coagulation is very useful, and I'll be touching on that. So it's called touch soft on the Steris device, or soft coag. And finally, for hot avulsion, I use the pulse cut on the Steris, or endocut I, and this is a little bit more cut, a little bit less coag. And I'll have a video showing hot avulsion, which I think is a very useful technique. So after you've pre-flighted the plane, pre-flighted all your supplies, you're ready to take off. So in polypectomy, like flying, lift is everything. So how do you lift? How much? It's good to inject proximally first. I use a dynamic injection approach, which I'll show a video of that. 10 cc syringes seem to be the best. They shouldn't be any larger, because then it's hard to inject. And the amount that you'll need to lift will vary depending on the size. It could be as little as 5 mils. It could be as much as 70 mils. Here's an example of injecting proximal. If you inject proximally, then the polyp tilts towards you, and it's easier to see the edge. If you inject the other way, it tilts away from you, and then it's harder to see sometimes. Sometimes, here's a large flat polyp, sometimes actually retroflexing the scope gives you a better view of how to inject. So here, you can see I've retroflex the scope, and you can see the polyp, you can see the margins of the polyp, and you can actually start injecting and start resecting in this position. And this one I managed successfully with a piecemeal resection. The concept of dynamic injection is really important. What I'm doing here is I'm putting the needle in, and as the assistant is injecting, I'm turning the wheels of the scope left, right, up, down, and that is dynamic injection. That seems to make the needle, it makes the lift more robust. So I very strongly recommend turning the wheels as you're injecting for a better lift. Occasionally, we have to mark around an indistinct polyp. This is a very subtle polyp, and using the tip of the snare, I'm putting dots around it so that I can make sure that I've identified the edges. This is obviously more commonly done with ESD, but in some cases of piecemeal EMR, it's useful. This is called a non-lifting sign. This is a person who had had a previous polypectomy. And I'm lifting here, and what you see, there's a jet of fluid. That means that there's submucosal fibrosis. And then with continued lift, what you see is everything's lifting but the polyp. It sort of remains at the bottom of a valley. And it shows it very nicely there. So that's the non-lifting sign. That doesn't mean that it's impossible to remove this, but you do have to use different techniques. And by the way, this blue, a little bit too dark. I mean, it's usable. One of the problems with using methylene blue that's too dark is it actually darkens the whole field. And so you can't see quite as clearly. Here's another example of a non-lifting polyp. This person had a previous attempt at polypectomy. There's still plenty of polyp left in this case. This is with NBI. You can see the edges. You can, and then you can see that polyp does, it's almost like a stellate scar there. That's where the polypectomy was. And again, with lift, you're lifting around the polyp, but the base of the polyp does not lift. So it's an important observation. And if you see that, you have to be careful and manage it in a different way than just grabbing it up with the snare. So you can see it's lifting. Polyp itself is not, it should be pillowing on top of the lift, and that's not happening here. That water jet, if you see the water jetting out, that's a good sign that it's tacked down. Now it may be tacked down from a previous attempt, or in some cases it's tacked down because the polyp is harboring malignancy. So here's a nice example of a very large polyp, but it's flat, and it's called granular. You can see it's pebbly. And if pebbly polyps like that actually have a very low likelihood of malignancy and tend to lift very well. So as large as this thing is, it responded very well to a piecemeal resection. Non-granular polyps, which is to say the bumps are bigger, have a higher chance of having malignancy and sometimes don't lift as well. Here there's a polyp in the region of the ileocecal valve, and you can see I used a DiLumen overtube. You'll see some plastic sticking out there, and that stabilized the position of the polyp, and then I was able to lift it, and it's lifting nicely. You can actually see it pillowing up on that blue. And here I'm starting with a regular braided snare. And what happens very often with the soft wire snares is you can see it. I wanted to grab more and it slipped, and I did get some polyp, but not a lot. So I switched to the Histolock snare, which is a stiffer wire and very precise resection. And I just go piece by piece, and the Histolock recruits tissue into the snare very nicely. So I really like it for very flat polyps and sessile polyps. And you can see this is a successful piecemeal resection of even a very large polyp. The Histolock did a great job with it. And I applied clips at the end. Something that's gotten a lot of attention in the last couple of years is snare tip soft coagulation, or STSC. This was described in this report from the Sydney group. And the problem with piecemeal resection is if you go back a certain percentage of the time, there will be residual polyp. And that's the thing we're trying to avoid. It could be as 15% or higher in some cases, sometimes even 20%. And what they found is that they take the snare tip and use soft coagulation and burn the edges, it decreases the recurrence fourfold. And so rather than having a 20%, is down 5 or below. So I like to demonstrate that. And this is something I think we're going to be doing pretty consistently going forward. So this, I did a piecemeal resection here, and I have the coin tip snare. And what you'll see is the tip of the snare. I'm basically using soft or touch soft coagulation and just kind of touching up the edges. And you can see it gives a nice white border after doing the snare tip soft coagulation. So this is done to prevent, to decrease the chance of residual polyp being there when we bring the patient back. And I have found that the coin tip snare is really, it's a nice configuration with that. It has sort of a flat tip, and it does this quite well. Actually better than other snares that I've used. This is a nice little clip from a case I did just yesterday. It shows a few things. It shows first underwater polypectomy and then snare tip soft. So the polyp, underwater, the polyp lifts, it stands up more. This was very flat without, before I flooded the area with water. And here's the coin tip snare. And I'm able to recruit that entire polyp nicely and nearly unblocked. If there's a little bit, after the resection, you can see there's a tiny corner of residual polyp on the left. Another advantage of the coin tip snare in this case is I have the 3 sizes, so now I can use the small size and just clip off that last little bit, and then I use the tip for the snare tip soft coagulation. According to the original reports, you don't need to lift for underwater polypectomy. In this case, I did lift and did underwater. So snare tip soft coagulation, STSC, remember that because you will be hearing a lot about that. And it's something that will decrease your recurrence rates, according to these recent studies. Now, how about a large stalk on a polyp? What should we do about that? Personally, what I do is I inject the stalk with epinephrine, and then I cut it with a coagulation setting, and then clip. I know that there's a technique described where you use an endoloop and you cinch it around the snare. I have stopped doing that. I find that the endoloop, it's soft and floppy, and sometimes it's extremely hard to get it around the snare head, the polyp head. Whereas if you're using a metal snare, it's stiffer and it's easier. So if you do the injection, it seems to take care of those vessels, at least temporarily. And then as you'll see in my next example, then I'll clip them. So this is a sizable polyp, which eventually I found, I was able to find it's on a broad stalk. It was not immediately apparent that this was a pedunculated polyp. You can see a long, thick stalk there. So in the manner that I described, I'm injecting epinephrine right into the stalk. Any vessels that are in there will spasm. Then I go in with my snare, a large snare, get it around. Snare at a place that's not too close to the base, not too close to the head of the polyp. And again, you should use coagulation setting here so you get a good cautery. And then that's the resection base, and it's completely dry. There's no blood, and I found this to be a very beneficial technique and safe and much easier. The endoloop, I just can't recommend the endoloop because of the difficulty sometimes in getting that over the polyp head. Regarding tattoo, I feel obliged to mention that if there's a large polyp, and you can see this very large one, if you're going to tattoo, don't tattoo next to the edge. It's what happens is if you're going to refer the patient for an endoscopic treatment, if you're going to refer the patient for surgery, then that's fine. But if they end up going to an advanced endoscopist for polypectomy, what happens is that the ink gets under the polyp and it fibroses it, and you'll have a non-lifting segment right there. So this is a better way to tattoo. So here's a lesion, and the tattoo is placed on the opposite wall, and that's less likely for the ink to get under the polyp and interfere with resection. if the patient goes for endoscopic resection. So encountering challenges, you may encounter challenge like this, a spin when you're flying. And so one challenge is incomplete resection. Now what do you do? Well, there's different things. You can use argon ablation. I'll illustrate a shaving with a snare, with the histolock snare specifically. Snare tips off cautery and hot avulsion. So the advantage of argon ablation, it's extremely fast and very safe. So here I am ablating, there's a little island there, I'm ablating that, I'm ablating the edges. It's very efficient. The downside to it is it has been found that the polyp, the rate of finding residual polyp on repeat colonoscopy is higher than other techniques. So albeit fast, it may not be the best way to ablate residual polyp. There's the technique of hot avulsion. So on this Asteris machine, it would be pulse cut, or there's an endocut eye setting. And hot avulsion is very useful. So here's an example. What I'm doing is I'm grabbing tissue with the hot forceps. So I push out, I grab tissue, and I'm stepping on the pedal as I'm pulling, and it avulses tissue. And this can actually be done hot or cold. Here I'm using hot, but it's a great way of removing residual polyp. And if the size is not too big, it's efficient. If you have a very large area, it takes a long time. Cold avulsion has also been described. I like the hot. The hot doesn't ooze after you pull it off, and the cold, there's some oozing, which interferes with your view. So here's a polyp. It's a residual polyp at a polypectomy site, and you can see there's non-lifting. It's lifting around, but not, the polyp itself is not lifting. I might mention also that here I'm using a cap, so it's very helpful holding the tissue apart. So here I'm actually using a histolock snare and just shaving it off. And with the histolock, you can be very precise of where you're shaving. I'm just shaving off the elevated part of the polyp. And then after a while, I've shaved off all I can. And there's a very small amount of polyp left, as you can see in the corner there. So then I'll use the hot avulsion technique. Again, reach in with a hot forceps and then pull away as you step on the pedal. And it very cleanly removes tissue. It's a very gratifying technique. The key, one of the keys is to actually pull away as you're stepping on the pedal. And by doing so, I don't think there's any risk of additional thermal injury to the wall. But you can see the polyp that was there, gone. That's the hot avulsion technique. How about emergencies? Well, when I was learning to fly, they tell you keep flying the plane. So don't just like throw up your hands and watch the plane go into the ground. Do everything you can to keep it flying. So you prepare for hemostasis. I like to point out the usefulness of a hemostatic forceps. I have a nice clip of that. If you can't see anything and there's blood everywhere, you can always inject epinephrine. It sometimes will slow it down enough where you can find the exact bleeding point. The clear cap is very helpful because you can flood the cap and you can clear away the blood in one area, and often that makes the difference of being able to identify the exact point that's bleeding. And clips are often used. So here's a nice example of a use of a hemostatic forceps. This is a big ugly polyp, I'll grant you that, but it did lift. It completely lifted. So as a result, went ahead with a large snare. Was able to seat that down. And there's a nice on-block resection here. So we were very happy about that. And there's some oozing and pulsatile oozing even. And now it's actually spurting. And you can actually see the vessel. It's a little arterial on there that's bleeding. So we did what most people do and what we usually do, which is, let's just clip it up. And what happened here is the clips didn't really hold. even though you think they should have, and the thing is still bleeding despite the clips. So what we did is did what we probably should have done in the first place, is we reach in there with a hemostatic forceps. And if you identify the bleeding point, when you reach in and close the forceps, if you got the point, it'll stop bleeding. So you see we grabbed, still bleeding. So that was not the point. So let's pick some other spot over here, grab, and it's like the bleeding stops. So we know that that little artery that's bleeding is right there. Then you can use the touch soft or soft coagulation here to coagulate that vessel. The advantage of the soft is the depth of burn is not very great, so it's very safe. And then afterwards, we clipped it up. You know, I'll be talking about the padlock clip later. And, you know, arguably in this particular case, padlock would have been quicker and cheaper. I mean, there's 5 clips there. That's more expensive than 1 padlock, but it could have closed that up with a single padlock. If you don't have a hemostatic forceps in a pinch, you can use a hot biopsy forceps. The key is to reach in, find that little artery that's bleeding, and then pull back a little, and then use the touch soft or soft setting. As far as clips, you clip up a resection or you leave it alone. This was one of the early studies. It's from Indiana University group, where it was a retrospective study of over 500 polyps, sessile polyps, over 2 centimeters over a 12-year period. And what they found in this retrospective study was that the bleeding rate of unclipped was higher than partially clipped, which was higher than fully clipped. And this, I think this really got a lot of people interested in clipping up polypectomy sites. Here was a study from Japan. This one was a prospective randomized trial of over 3,000 polyps, polyps that were less than 2 centimeters. And they found that prophylactic clipping was not useful for polyps less than 2 centimeters. There was no significant difference in bleeding incidence. And you can see it's about 1% here. This was one of the most recent trials that was done. This was published here in abstract form in 2018. It was over 900 patients with polyps over 20 millimeters, and they were randomized to clipping or no clipping. And what was found was, if you look at the risk of post-procedure bleeding, you can see it really made a difference when the polyps were proximal, right colon. Went from 9.6 in the control group to 3.3 in patients who were clipped. Distal polyps, no significant difference. So the takeaway was that for large proximal colon polyps, perhaps they should be clipped. An interesting thing that I've also noticed from this is even with clips, you see it's not 0% post-procedure bleeding. So there still can be bleeding even with clips well applied. So clearly, let's consider clips for patients who are going to maybe restart an antiplatelet agent or who have a coagulopathy, renal insufficiency, and large polyps in the proximal colon. For those situations, it makes sense, and there's data to support clipping those. For a smaller polyp in the left colon, probably no data there. So this was a large EMR site, piecemeal EMR site, very low down in the rectum. And as we pull the scope back, you can actually see these large veins, which are actually hemorrhoidal veins. But I'm showing the zip up technique. So for the zip up technique, the first clip is actually in normal tissue above. And what it does is it brings the edges together. And then with subsequent clips, you can just sort of walk down and you can close some impressively large resection sites with clips that are all lined up. So that's the zip up technique. I'm sure everyone here that's attending has dealt with a delayed polypectomy bleed, and this is what you typically see. It's like an ulcer with a visible vessel on it, not bleeding. But since we're standing there, we'll put a clip on it. I mean, arguably it's not bleeding. Why do you have to do anything? But you made all the effort to get there. You might as well just put a clip on it. This is the so-called target sign. This is the original report, which was in 2011. So on the resection side, you see a target, and on the resected piece, it looks like a target. And basically that center part is the muscularis propria. So this was an area that didn't lift, but was snared off on block. That's called the target sign. This was an example that I had, and it was somewhat confusing. It wasn't clearly a perforation. So I lifted, I removed a polyp, and what was odd, a couple things. One, I mean, you're still seeing blue after a resection, and this was not blue, it was red. At the same time, it's not like I'm looking at the peritoneum. So I wasn't clear that it was a perforation. But if you look at the specimen, it has a target on it. And that inner white band, that's muscularis propria. So I infer from this, the image on the left, that the perforation was actually on the mesenteric side. So it wasn't on the anti-mesenteric side, which would have been I would be looking at the peritoneum. It was on the mesenteric side, which is why it didn't look like a perforation. But I did clip it up right away, mainly because it looked funny. And then later on, I appreciated that this was a target sign. Now for closure perforation, I really, if possible, I use the over the scope clip. It's very quick. It can cover a large area. And I do like the padlock clip because it's so easy to set up. The setup is just a few short steps. Now, let's say that there was a perforation or something that you wanted to close with a over the scope clip. Consider marking the site with a regular clip first, because then it's easier to find the defect when you go back with the scope. An example would be, let's say that you noted that a perforation was caused during a polypectomy, or possibly even during scope insertion somewhere in the colon. Rather than just coming out, loading on the padlock and going back, it can be very hard to find that spot because it's often very small. What you can do is put a little through the scope clip at the site and then go back with the padlock and identify that. And it's okay if that clip comes inside the cap of the padlock. It doesn't interfere with deployment. Here's an example of a case. This patient had a screening colonoscopy by one of my colleagues at an outpatient endo center. The endoscopist did notice a perforation and tried to close it with clips, as you can see. So there's a hole there. There are clips in and outside, but it was not possible to close it. It was a very angulated part of the sigmoid. So I pulled out the clips I could, and there's the perforation. Loaded on the padlock. And here I'm targeting that clip and the perforation. So the clip is inside the cap of the padlock, which is perfectly fine. So that's centered, targeted, full suction, hold that for a few seconds, and then deploy the clip. And it completely closed it, and the patient did very well. It was 4 hours after the perforation that I got this done. Patient did very well. And obviously she was admitted for observation, but did not need surgery, had a very uncomplicated course after this. I will say that I did tattoo the area, just in case the person ended up going to surgery. It's good to tell the surgeon, here's where the problem is. That's why I put the tattoo. But as it turned out, she did quite well. Here's an example of use of a padlock for post-polypectomy closure. This is a large polyp. And after polypectomy, there was bleeding. And in this case, I have to say it was harder to see the exact site of bleeding as opposed to the last case. I'm reaching in with a hemostatic forceps, but I believe I ended up injecting some epinephrine to get this thing slowed down so I can see. So in this case, instead of using a bunch of clips, I used one padlock. And again, you just center it, target it, just center it, suction for a few seconds, and deploy. And it got it. And actually, since I had the hemostatic forceps out, you can see these tiny little arterioles, and that's what caused all that bleeding. And I probably didn't need to cauterize these with the touch soft, but you know, I'm had the forceps open, I'm standing there, I'm looking at this, so I did cauterize those. And so that was a nice example of managing a post-polypectomy oozing lesion with the padlock. So finally, just in summary, my final thoughts about this subject, fully assess the polyp first. If you think it's likely to harbor cancer, probably tattoo it if it's in a location that it needs to be tattooed. There was a whole discussion about assessment of the pit pattern, which I thought was out of the scope of this talk, but that's something that is probably useful to do. If you think you're going to send it to an endoscopic specialist for resection, then don't snare part of it. And arguably, you don't even need to biopsy it. I mean, there's a polyp there. You're sending it to be managed. The problem with snaring or biopsying is that you end up with fibrosis, and it makes subsequent lifting very difficult. So I've had polyps where I got out most of the polyp, but the part that was biopsied was stuck down, and it took a longer time to manage that. And of course, if you're going to tattoo away from the lesion. Rectal lesions don't need to be tattooed. Cecal lesions don't need to be tattooed, but other lesions in between can benefit from tattooing. And another situation I use tattoo in the colon is, let's say I did a removal of a complex polyp. I sometimes will tattoo that area to make sure I can find it on the repeat colonoscopy. Adequate lift will prevent a perforation. So watch the lift. It should pillow up, as in those examples. And if you see it pillowing up, that was an adequate lift, and then you can go ahead with the snare. If there's some question that it didn't lift right, then one has to be more careful. And certainly, you have to take your time. With these cases, you can't really be in a rush. So thanks for your attention. I really appreciate your being here tonight, and I hope that you got something out of this.
Excellent. Well, thank you, Dr. Diehl, for sharing your recommended tips and tricks. I find your 7-step checklist along with the dynamic approach to flying very engaging and easy to follow. If anyone has any questions, please feel free to submit those in the chat box or in the Q&A. We do have some time with Dr. Diehl to address any questions. But one question that I would love to start with, if you could share your experiences, but what is your recommended approach for the resection of polyps on folds? I know you went through quite a few different cases, flat polyps, or some more challenging cases, but oftentimes that could be a struggle for some physicians.
Yeah, certainly. Polyps on folds can be hard, particularly the proximal edge can be very hard to lift. I highly recommend use of a cap, because with a cap, you can hold the fold down. You can probably get the proper amount of lift on the proximal edge. And that would be one thought. I like the Histolock snare because it's from its stiffness, it's very controllable. So, and if it's large enough, if it's like more than 20 millimeters, 25 millimeters on a fold, I find that the full thickness resection device is useful there, because if it's on a fold, it's actually pretty easy to draw into the cap.
Excellent. You mentioned caps for folds, and what other applications do you recommend using a cap? I saw throughout your presentation you had some on there for different hemostatic procedures or specifically underwater colonoscopy. But
Yeah.
caps are something we're starting to see a little bit more in different webinars, especially on this platform. It's kind of a hidden gem in a portfolio.
Yeah, that's a good way of putting it. It really is a hidden gem. I have to say I use it for all my Barrett's cases, all of them. I mean, if it really holds the walls of the esophagus open so that I could see what I'm looking at, I can do biopsies more accurately. So for Barrett's in the esophagus, I love caps. for anything the duodenum, so a duodenal polyp, a duodenal AVM, it's great for holding back folds. And I would have to say if I'm going after a polyp, I know there's a polyp there in the colon, I will typically use a cap. I more often regret not using a cap than regret using a cap. So it's good to make sure you have the correct sizes. The adult colonoscope takes a different size than the slim colonoscope, takes a different size than the gastroscope. So we have all of those on hand.
Excellent. We have a question in the chat. What estimated % of your incomplete resection cases do you use APC instead of hot avulsion?
Yeah, I have to say I've more or less gotten away from using argon to touch up incomplete resection, mainly because if you look at the literature on recurrence rate, it's higher than with hot avulsion or snare tip soft cautery. So I pretty much don't do it anymore, I have to say.
We have another question from Sai in the chat. Thank you for the informative presentation. And what is the advantage of using the pulse setting for sessile serrated polyps?
It's a great question. I will say that the sessile serrated polyps are flat, and I use the pulse setting for flat polyps. So that's why I'm using it for the sessile serrated polyps. There was a study published recently looking between pulsed or forced coagulation. And in that study, at least, they claim that there's no difference between the two, but I would say it's endoscopist preference at this point. It's hard to point to a study showing that it's safer or better, but I do feel for flat polyps, I don't want to apply a lot of energy to the wall, whereas with a pedunculated polyp, I'm okay applying more energy, particularly with a thick polyp stalk, so I do want that coag setting.
Thank you. Also in your presentation, we had a nice discussion on padlock with those videos that you showcased, but there's also need for through the scope clips. So if you could talk through some of your thought track on when to pull out an over the scope clip versus a through the scope clip.
Good, that's a very good point. Certainly through the scope clip, I mean, the immediacy, you're looking at it, you can go down and close something. If it's smaller, a through the scope clip is certainly easier. And I still use multiple through the scope clips for closing large EMR sites. For something that looks like a real perforation, if it's the size where it'll fit into the cap, I think there may be an advantage to over the scope clip. Or if it's a lesion that size-wise it fits the cap, but you think you're going to use 3 or more through the scope clips, it may be cost saving to use just one over the scope clip.
Yeah, some of those cases that you showcased, there's quite a few of those clips on there, so I know that can get costly, but they are pretty easy to use. Thank you. One of your checklist items was talking about lifting, and I know there's quite a few lifting solutions on the market or homebrew options, but when do you decide either the size that you should inject, or I know you discussed your color preference, but just there's such a variety on lifting solutions, taking a little bit of time to discuss that.
Right. This also is endoscopist preference, and people sort of get used to maybe using a formula or recipe that their teacher used. I think it's more pertinent to EST because you do want something more viscous. Epinephrine sometimes has benefits, particularly in colonic EST, gastric EST. But for standard piecemeal polypectomy, I have not found an advantage. I don't miss not having epinephrine, and I don't miss not having some thickening agent. I find that the saline, the coloration agent is useful. One, it helps define the polyp, and two, if you remove a part of the polyp, if you see blue at your resection base, that's a good sign. That tells you that it's not too deep. So it's an indicator that your depth of cut is good. So That's why you can do it without adding blue, but you still need the saline lift, but you don't have that warning built in. So I guess in summary, for most polypectomies, I don't feel that epinephrine or a thickening agent is strictly required, but it's personal preference.
Thank you. We have another question in the chat. Thank you for the excellent presentation. Are there any specific clinical considerations when doing underwater colonoscopy versus standard colonoscopy?
Clinical considerations. Well, the prep has to be really good if you're going to do underwater, because if the prep is not clean, then you're looking through a very cloudy water. So it may not be advisable if the prep is not good enough, because you end up spending a lot of time trying to clean up and do it. But you should, I would encourage people to try underwater. So find an area, flood the area with water. And, I'm still lifting at this point. I haven't taken the step to do the non-lift underwater, which is well described and considered safe. I still do a little bit of lift, but like in the case that I demonstrated, it made a polyp which might have been fairly flattened out and larger, very much smaller, that it was able to manage it very well with a snare.
Excellent. And then if anyone does have any additional questions, we do have a few more minutes, but just another question to ask. When do you decide to move from in-block resection to piecemeal? I know you showed quite a few cases of some nice large in-block resections, but piecemeal also has a nice application.
Right. Also a very excellent question. So on-block resection is best if you have a polyp that has a very worrisome pit pattern, possibly has high-grade dysplasia, early cancer. Then having an on-block resection is very beneficial. Now, to get an on-block resection, often it requires EST, which takes more time, more expertise, more equipment, and everything. I have to say, in the rectum, there is a benefit to get an en-bloc resection for larger polyps, maybe 20 millimeters and up, to get them en bloc, because if, let's say that the polyp harbors some cancer or something very early, or some high grade area, if you have en bloc, you can have assurance that you've gotten it completely out, whereas you don't have that with piecemeal. So, and the consequences are big, because if it's, let's say it's an early cancer in some other part of the colon, you can do a segmental resection or even a right hemicolectomy. Whereas in the rectum, it involves a rectal surgery, a proctectomy, which is a much bigger operation. So for rectal polyps, it's probably preferred to do those en bloc, unless it has that granular appearance, which we see. And if it's granular, then piecemeal should be fine.
Excellent. Okay, we have another chat question, maybe.
I see a question regarding what criteria do you use when choosing between cold snare and hot snare? So personally, I mean, it depends on the size for me. If it's a smaller polyp, like 10 millimeters or less, or maybe even up to 15, cold snare works great. There were reports of using cold snaring for even larger polyps, 20 millimeters and up. I still prefer hot snare with the pulse cut mode for in that situation. But for smaller polyps, like certainly 10 millimeters and less, I am now going to cold snare. Other situations, there's some data emerging that if someone has a risk for bleeding, that the post-polypectomy bleeding rate seems to be less with cold snaring. So that may be another good indication there.
I think cold snaring, along with how you mentioned the snare tip, that's another area along with underwater colonoscopy that we'll continue to see more research and papers and discussion. So
Yep.
was
No
a
doubt.
great presentation touching upon all of those aspects. But if there aren't any further questions, I would just like to thank you again, Dr. Diehl, for taking the time to meet with us this evening. I'm sure you've had a very long day, but we really appreciate your time and all the different topics that you discussed. This webinar it is recorded and it will be posted later on our YouTube channel. If you're interested in watching any of these videos again or taking notes on the recommended tips and tricks.
All right. Thanks for having me. I appreciate it. Thanks to everyone for attending. Have a good night.
Thank you, everyone.